Good afternoon, everyone, and welcome to today's Menzies Research Seminar. As we begin, I'd like to pay my respects to the traditional owners of the land, the Larrakia people, and extend that respect to all Aboriginal and Torres Strait Islander people who are joining us here today and online. It's my absolute pleasure today to welcome Professor Paul Lawton and Dr Solomon Woldeyohannes to present to us on the Return to Country project. We'll have some time for questions at the end, and we'll throw to people in the room first and then to those joining us online. But without any further ado, Paul and Solomon, I'll hand it over to you.
Thanks, Patty. I guess I'm probably known to most people in the audience in person and online, but I've been in the Territory for many years, but the last 2 years in Melbourne at one of the whitest hospitals in Australia, in contrast to my entire career otherwise. And I'm here today to present one aspect with my colleague Solomon, one aspect of the Return to Country study. I'd like to also acknowledge the custodians of the land on which we conduct our research, which is right across the country. We're joining you today from Larrakia country. We'd also like to acknowledge those who have passed away with end-stage kidney disease, including, as part of this study, 2 of our Return to Country project chief investigators have actually passed away to the study so far, which is very sad. We acknowledge their contribution and their critical contribution to making this what it is so far and what it will be. In 1996, I think it was, the study was, anthropological study was done in Central Australia by Jeannie Devitt and Anthony McMasters, a social anthropologist, Jeannie, a non-Indigenous social anthropologist, and a First Nations man, Anthony, leading to an academic paper, but also these 2 critical publications in 1996, exploring the experiences of people on dialysis in Central Australia. The key point about this, if you haven't read them, one of the things, if you've got an interest in the topic of Indigenous health, I would strongly recommend you read them. They're still in print at the Institute. IAD, what's IAD stand for? Can't remember, but it's still in print. You can get them at Red Kangaroo in Alice Springs. One of the key points is the yearning of patients who had relocated or been socially dislocated to Alice Springs from remote communities. Their yearning to be home on country and their feeling of extraordinary social dislocation to be stuck in town in Alice Springs on dialysis. Then we have a whole series of papers coming out of the impact study. The impact study was a national qualitative study of around up to 250 patients, a large number of whom were Indigenous, comparing and contrasting with the non-Indigenous experience in regional remote Australia. And a number of publications came out of that work in the early 2000s, publishing right through into the mid-teens. And again, for those of you who are interested, these are really readable and interesting papers with evocative titles, as you see here. I draw your attention to my favourite, which is this one, Looking Back to My Family, the Indigenous Australian Patient's Experience of Hemodialysis, and the important clarity with which it actually explored precisely this issue of social dislocation. And then, of course, other authors in North Coast New South Wales have produced similar, reflected similar qualitative experiences in rural, not remote or very remote, but in regional northern New South Wales as well, amongst Aboriginal people in that region. And then as part of the impact study, there's been a really important insight from 2012, a survey of a discrete choice experiment of Australian nephrologists that unpacked, and I'm happy to take questions on this later, unpacked, and I was a research subject, I wasn't an author, I was a subject of this paper, the bias Australian nephrologists had in relation to the issues of what's called non-compliance and Aboriginality in reflections on the kidney transplant waiting list. So the return to country study is based on these basic data. We see that around Australia, in every state and territory, between 35 to 40% of non-Indigenous patients receive treatment in satellite or facility hemodialysis centres. You see the Northern Territory numbers bounce around a little because they're smaller non-Indigenous numbers. You see in every state and territory, we see similar figures. So the experience for non-Indigenous patients requiring dialysis or a transplant is, as I said, 35 to 40% getting treatment in the most dependent space with the worst quality of life for satellite hemodialysis. The picture is very different for Indigenous First Nations Australians. In every state and territory you see there, the number is far higher than 35 to 40%. There are some recent changes. You see these figures are updated to data to the end of 2021. And those changes include a small dip in the Northern Territory since 2018 and a larger dip in Victoria in the proportion of people treated in satellite or facility hemodialysis. I'm happy to explore why that might be later if you wish. Part of the reason it might be is related to an MBS item that Alan chaired a committee, Alan Cass, for the MBS review process into renal item numbers. And one of the things that he and the committee were able to get across the line was for the very first time an item number for hemodialysis in very remote areas. And this is actually the blurb explaining what that item number means. And it means that any patient can receive dialysis, hemodialysis, facilitated by staff members of various sorts in very remote areas, defined as modified Monash Model 7, and we'll come back to that when Solomon's talking, and as a day-stay admission under Medicare. And that's the first time that Medicare has actually been able to be used for dialysis funding from November 2018 onwards. What we have is, as I said, this experience, which is radically different. I looked at it in another way just because of this item number for modified Monash Model 7. So the very remotest patients from very remotest communities in cumulative national registry data. And you see here, there are two graphs superimposed on each other. One is the dotted line is you can see that the risk of death from commencement of treatment is the same over that time period, whether you're Indigenous or non-Indigenous or in a very remote area. But what is very different is you see there's a great separation in the curves of the risks of, or the chances of a patient getting home back to their very remote location, where non-Indigenous patients, numbers small, you see there with the steps, are much more likely to get home to their very remote home location than Indigenous patients. And so we came up with the Return to Country study, which is a mixed methods national observational study with some waves of intervention that I'm happy to discuss later, and several domains of measurement, including patient level experience measurements qualitatively, as well as policies and procedures audits and at service level. It's really a health services research to understand why there's this disparity in the experience of Indigenous patients compared to non-Indigenous patients from remote locations getting home, and to test health service changes the willingness of health services to change to improve Indigenous experience. So what I'm going to do now is to hand over to Solomon for some work to look in detail at, because the unit of change is the centre, not the nation. In many ways, national policy has been set, but are centres able to deliver care appropriately, and can we compare one centre to another? So I'll hand over to my friend Solomon to explore this in more detail.
Thank you. I'm Solomon, a research fellow under the Return to Country project, and Professor Paul is my boss. He's just being humble. He kept saying he's friend. He's my boss. The key question is, are we able to send patients close to home? And we are seeking patient level factors actually at the moment to try to predict whether patients can be treated close to home. So to give you a background, we tracked patients from beginning to 1 year period, and at the end of 1 year period, we assessed whether the patients are close to home using postcode. If patients achieve same postcode as the original postcode during presentation for treatment, then we classify them as getting treatment close to home. If the postcode is different at the end of 1 year, we refer them to be in a different location. That means they're receiving treatment at center level or hospital level. So we approached the data analysis into four. We have got the full data set with Indigenous and non-Indigenous patients and remote and non-remote status. We split the full data set into Indigenous and non-Indigenous data, and a further subset of the data set with remote and very remote data. So with full data set, as you can see, 90% of the patients are getting treatment close to home, whereas with Indigenous data set, 75% of the patients are getting treatment close to home, while 25% remain not going to home. With non-Indigenous data, 94% of the patients are going home or receiving treatment at home, whereas with remote and very remote area, about 70% are getting treatment close to home, and 30% remain at centers or hospitals. So we have adopted a methodology developed by ANZ Data Center, Registry Center. They used mixed effects logistic and Poisson regression model to assess performance of centers in reducing mortality. And in our case, we used this methodology to predict status of patients with regard to getting treatment close to home at 1 year period. So as I said, using this in this analysis, we based our prediction based on patient level data. We didn't include any center level or hospital level covariates, which might be more predictable. And Professor Paul will discuss this center level covariates later. And we also included de-identified centers as random effects. So we have got a mixed effects logistic regression model to predict status of patients at the end of 1 year. So mixed effect model, which consists of a constant term, a fixed effect, which consists of both demographic and comorbidities factor, and a random effect, which comes from the center variability, and an error term, which accounts for those unexplained variations, which could be more of structural predictors that we didn't account in the model. So using this model, we calculated the standardized incidence ratio, which is a ratio of observed number of patients getting treatment close to home over the predicted number of patients getting treatment at home. This standardized incidence ratio is used to assess centers or hospitals' performance in sending patients close to home. So our data is end-stage kidney disease treatment registry data. It covers, for the period 2005 to 2017, all patients being included. So with 4 data sets, we have 4 separate analyses. So with the full data set, this is an example of a random effects logistic regression model results to predict the likelihood of getting treatment close to home. So using the model, we were able to identify age, Indigenous status, the Monash modified model scale, 4, 5, 6, and 7 to be statistical predictors of getting treatment close to home. And the last predictor, which is found to be statistically significant, is being diabetic. So as you can see, there is a discrepancy between Indigenous and non-Indigenous patients in getting treatment close to home. The 1.75 odds ratio means non-Indigenous patients are 75% at higher odds of getting treatment close to home as compared to Indigenous patients. And when we see the Monash modified model scale, you can see that the odds of getting treatment close to home declines as we go far from the inner regional areas to the very remote area. So the MM7 being almost 63% less likely to get treatment close to home. And diabetics is, it shows 21% less likely to get treatment close to home. So this is a funnel plot to assess centers' performance in sending patients close to home. So this funnel plot, the vertical line being the log standardized incidence ratio, and the horizontal line, which is an effective sample size, it's a concept which we adopted from the ANS data registry. The statisticians, they are applying this method to get more sensible meaning for assessing performance of centers in reducing mortality in their case, and in our case in sending patients close to home. So the funnel plot comes with 2 dashed lines, the blue dashed line being the 95% false discovery rate, and the red line being the 99% false discovery rate. So any center which falls within the 2 blue lines or the red lines is considered to be an average performing center, which is good in sending patients close to home. Whereas those centers above the 2 lines, dashed lines, it's considered to be performing well in sending patients close to home, whereas the centers below the 2 lines are considered I would say, underperforming centers in sending patients close to home. We have highlighted those 2 centers so that you can track them in the next few slides regarding their performance in sending patients close to home. So I think I have explained most of the things here. I can, so this is just with the full data set. So we will see the next slide will be for Indigenous patients only. So with Indigenous patients only, as you can see, the 2 centers are still staggering in sending patients close to home, whereas there are quite a few centers sending patients close to home. I would say this center is performing well because it has a very good effective sample size, and effective sample size is related with a large number of observed outcome, and that may be a good observation for those centers to be somewhere around this area. When we see non-Indigenous data, you can see most of the centers fall within the false discovery rate, which means they are, sending patients close to home in most of the cases, except this center, which is still far from, performing well. So the main purpose of, I think the main purpose of this presentation is benchmarking the experience of those well-performing centers or hospitals in order to improve the services for patients with ESKD. This one is a very distorted result due to large number, discrepancy in size. In a sense, size of centers, or the, how do I say it, the volume of patients they see per center. So these 2 centers, as you can see, they lie in the far rightmost part of the plot with 60,000 patients, which is unrealistic in terms of the mathematics. So what we did is we removed the 2 centers which distorted the finding, and then we found a better result without having those centers with large number of patients. And this part of, this finding represents the remote and very remote data with centers lower than 200 patients per year. So you can see that the 2 centers here, one of the center, which is H35765, is still below the standard, below the average performance region. So I will leave the floor for Professor Paul, and I'll be back with question and answer.
Excellent, Solomon. So the key point is that when we're thinking about what is fundamentally health services research, how do we benchmark services against each other using national registry data? And as I said, that Solomon's explained, where we've modified tools used for standardised mortality ratio to actually reflect a standardised incidence ratio of a patient-centred outcome, that in this case, getting closer to home. The next steps, Solomon showed you data that we've used to work on these models to the end of 2017. But of course, as I showed you, the really interesting thing is what happened next from 2018 onwards. We also have, Solomon pointed out, we had this mixed effects or fixed effects model with the table, variables showing the fixed effects, the effect of diabetes over the population at large, but also then the random effects of the variation in hospital in different centres. We can actually and are collecting centre-specific variables to do with the policies and procedures audits at each centre, and an anonymous staff survey about staff attitudes, beliefs and behaviours at that centre. So we can use in aggregate to see if that explains some of the variation in performance between centres. We are feeding back to centres with identification of those centres. So those 2 centres we highlighted will learn about their below average performance. We're not going to tell you who they are, but we're telling them who they are. And we are funding through the Return to Country study pilot activities at each participating centre promoting cultural safety. So that ends our part of the presentation. I guess we'll open up for questions, and Alan, of course, has a question.